Hi. This feels like the end of a very long trajectory of 3 years, although it's work in progress, in which we try to update the pediatric guidelines for resuscitation 2021. We had a fantastic team, which you can see here, and only Florian and Ian reported a conflict of interest. It's been a trajectory, like I said, of 3 years in which we, as a pediatric writing group, explored 80 rapid reviews, part of them as in the trajectory of the ILCOR evidence review, part in addition. We finished this initial reviews in November 2019, but then, of course, as you know, COVID happened and we needed to do a search update, which happened June 2020. And in the meantime, also, and you can find them in the literature on the website, made COVID-specific guidelines. We based our guidelines on science, but definitely also on what they would have on impact on education and implementation. And we aimed them to be simple and uniform, but contextual in nature. Some key concepts that are valued throughout the guidelines, these are about children, which we define from the age of 0 to 18 years, with the exception of newborns at birth, and with the possibility for anyone who appears an adult to also have the adult guidelines used. We use the concept of competent provider throughout the guidelines, which is defined as having sufficient knowledge, skills, attitudes, expertise to perform and lead a procedure to the level demanded by society, knowing that the term sufficient is difficult to define and eventually comes down to self-reflection. But it's an important concept, and we defined it for different procedures and actions. ABCD is still a key concept throughout our guidelines. And we also emphasized very much the importance of a team-based approach. We do not specifically discuss the chain of survival as such, but of course, these guidelines were built up in a way that we move from pre-arrest situations over basic life support towards advanced life support and post-ROSC intensive care, which are, as it happens, the 4 parts of the chain of survival. And this chronology and these 4 links are how our guidelines are built up. Starting then with the pre-arrest situation, this is the ABCD approach in a way. We focused on oxygenation, ventilation, and circulation. For oxygenation, we emphasized the importance of oxygen titration to a specific goal, which is defined as a saturation between 94 and 98% in general. One should not give preemptive oxygen in children who do not have signs of hypoxemia or circulatory or decompensated circulatory failure, unless once it is impossible to accurately measure oxygen saturation or PaO2, then you should start with high FiO2 based on clinical signs of respiratory circulatory failure, and as soon as possible, once it is possible, titrate FiO2 towards that goal. For ventilation, we emphasize the importance of backmask ventilation as the first line, and this is a skill that all PLS providers should be able to use should be competent in. And we emphasize the importance while doing this procedure to avoid both hypoinflation and hyperinflation by using the right technique, the right bag, etc. For circulation, we identified actually no parameter that would be able to serve as a goal or a diagnostic tool for circulatory failure. And so the treatment of circulatory failure and the diagnosis should be tailored to the individual. We limited fluid boluses in dose to 10 mils per kilo, but obviously, based on more rapid reassessment, it might be needed to give repeated fluid boluses in children in shock, up to 40 to 60 mils per kilo, as was in previous guidelines also written. Those children who do not have signs of decreased perfusion or even signs of fluid overload should not receive repeated boluses. We advocate the use of balanced crystalloids as a first choice, although normal saline can be an alternative still. And in case of hemorrhagic shock, blood products are the thing the child needs. And finally, we also emphasize the importance of early use of vasoactive drugs being given either central or peripheral. Good pre-arrest care should avoid the majority of pediatric cardiac arrests, but if and when it occurs, proper basic and advanced life support will make a difference. We do not longer focus on the duty to respond or other definitions, but actually kept three categories of people who can be attending a pediatric cardiac arrest. These people could be pediatric BLS trained, they could be BLS trained, or they could be untrained. Those untrained will be assisted by a dispatcher when they call 112. And the protocol actually is a pediatric-driven protocol. Those PBLS trained in pediatric basic life support, they should use the specific protocol, and that's in the next slide. But those only trained in adult BLS, they should do as they are learned there, ideally adding in 5 initial rescue breaths and focusing their techniques on the size of the child, obviously. So for the specific PBLS algorithm, and the algorithm is shown on the right side of the slides, the differences are not big, but we try to focus on 2 things, meaning time and quality. As for quality, this is the quality of ventilation and compression. Ventilation meaning that for competent providers, we advocate also in PBLS the use of a bag and mask ventilation. And for compressions, we focused on rate, depth, and recoil, all 3 of them for each compression. Although a 2-finger technique is still acceptable, we also advocate preferentially to use in infants, even the single rescuer, a 2-thumbed encircling technique. And for what concerns time, we try to decrease the amount of hands-off moments by immediately proceeding after the rescue breaths to chest compressions unless there are clear signs of life. We also indicate that the second rescuer should call EMS immediately, but if a single rescuer is attending a victim, then he or she should perform 5 rescue breaths and then also try to call EMS, provided he or she has a mobile phone with a speaker function. If there's no phone available, a single rescuer would first perform 1 minute of CPR. If there's 2 rescuers, the second rescuer would immediately try and collect an AED, but the lone rescuer would only collect an AED if that AED is immediately accessible and there's a very high likelihood of a shockable rhythm, such as in a witnessed collapse. Specifically for trauma, we identified that even in trauma, bystander pediatric basic life support should be performed, provided it is safe for the rescuer. And CPR has priority over spinal immobilization, although, of course, you should try to limit the amount of movement of the spine. There's no argument to specifically apply an AED unless there's a high likelihood of a shockable rhythm, such as in an electrocution. And if there's clear external bleeding, this should be controlled by direct pressure or even applying a tourniquet. As for foreign body area obstruction, the algorithm has changed in appearance, but actually is unchanged from a content perspective. There's a lot to do about anti-choking devices, but we clearly stated that these should only be used, up till there's more evidence, only be used in a formal study context. If there's then an advanced life support team attending, the algorithm obviously becomes more complex. It has not changed much from the 2015 algorithm, but again, we focused on certain quality and certain technical issues within these flowcharts. For defibrillation, the dose is still 4 joules per kilo, with a maximum dose that is similar to the adult one. But if there is a refractory shockable rhythm, then eventually after 5 shocks, one could consider escalating doses. Normally spoken, each shock is given as a single one, but for witnessed shockable arrests where the defibrillator is immediately available or attached in hospital, then a stacked shock approach, 3 shocks in a row, could be considered. For airway management within the advanced life support algorithm, backmask ventilation is the first choice. Once the child is intubated, if the child is intubated, it is possible to move towards asynchronous ventilation with continuous compressions and the ventilation at a rate that is a lower limit of normal age. This differs from the 2015 guidelines where it was always 10. Here we say 10 is for the plus 12, but this can be as much as 25 for the minus 1. We did not change the 4H, 4Ts as such, because this is a known concept and similar to adults, but we emphasize its importance. Saving lives has a lot to do with identifying reversible causes and trying to treat these. The 4H and 4Ts are similar, but we added hypothermia and emphasized hypoglycemia as potential reversible causes. And we deleted acidosis, as we do not believe that is a treatable reversible cause. Teams should consider if they are competent to use ultrasounds, and they should consider within a healthcare context where there's sufficient expertise and resources to initiate eCPR. This obviously is a fast forward and limited representation of a guideline that is contains a lot more and also explains why some of these choices were made, knowing that for some of these things the evidence was limited. But as we said in the beginning, it's not only about the science, it's also about education and implementation. And we try to provide uniform, simple guidelines that could be used and sometimes even adapted to your local situation. Thank you for your attention. May the force be with you.